Hi, I'm Dr. Bone.
Hi, I'm Dr. T.
Our topic that has been suggested to us is to talk about suffering. And what does suffering mean? Suffering is like beauty. It's in the eyes of the beholder, or it's in the life of the sufferer. So a patient has a disease state that may be at an advanced stage, or maybe they just learned about their diagnosis and they're brand new to the diagnosis. It could be cancer, that's one a lot of people fear. It could be heart disease, that's a very real one. It could be lung disease. COPD is something that many people suffer from. So suffering takes multiple forms, and it not just affects the patient, but I think it affects the family. Don't you find?
Yeah, I think it affects the family, and I don't think it's only physical suffering. There's emotional suffering and spiritual suffering
Good
that our
point.
patients are faced with. So it's sometimes easy to pinpoint pain, right? Pain and suffering.
Pain, I think, is a really common one that people associate pain with suffering, and they want their pain to go away. Do you think that's a realistic goal, for pain to go away?
Not usually. It depends on how long the pain is there. If it's an acute pain, then of course, you stub your toe. Once the toe's healed, the pain will go away. But our patients are chronically ill, and they've had pain for many years. So it's going to take time for us to get the pain to go away.
And I think sometimes pain is sort of like a toothache pain, where the pain is nonstop, it's night and day, it's unrelenting, it's ongoing. But I also think pain worries patients because they feel like my pain is not curable because my disease won't go away. My disease is there, it's advancing, and that pain is a sign of my disease.
Right. And then that's where I think also when you have physical pain that causes your emotions to run high, you can either be anxious or very sad, depressed, angry. So there's a lot of emotional component to the suffering that causes undue suffering. And of course, to family members, they suffer when their loved ones are suffering.
I took care of a patient, and his chronic disease state prevented him from being very mobile. But as a male, he felt that it was imperative that he be physically active and physically fit. So he and his family, when they would want to do an outing together, he would begin to have more pain the longer that they were away from home, and the more physically active he was, then his pain would become more bothersome to him, and then he would become short with the family and get more agitated and get more frustrated with them because he was feeling worse. So his family, of course, fortunately, was very compassionate and very as empathetic as they could be, very in tune to his pain, and they wanted him to get a power device so that they could go out and be active together as a family. He was so against that, so reluctant to do that, that it kind of impaired and affected the entire family. Everyone in the family felt like, we want to go somewhere, we want to do some things, but Dad is so uncomfortable if we're gone from home more than just an hour or two. And sometimes that hour or two may be in a vehicle just to get to their destination. By the time they get there, Dad already doesn't feel good, and we may not be able to stay very long because the more uncomfortable he becomes, the more time it takes for him to recover. So we get home late tonight, he may not feel good again for a couple of days. So sometimes that physical pain can cause emotional pain to the patient as well as to the family that affects the entire family dynamic.
Right. And then there's the spiritual suffering that we can touch on. We're not spiritual advisors. That's our disclaimer. But we see patients all the time. They're like, I went to church every week. I prayed. I read the Bible every day. Why did God give me cancer? Why did I get end-stage heart disease? Why am I having to wear oxygen all the time with my chronic obstructive pulmonary disease? So there's a lot of bargaining that occurs, and a lot of begging and pleading because they were good people. And why do bad things happen to good people?
And sometimes bad things do happen. I've had patients in the past tell me, I don't want to wear that oxygen, I'll get dependent on it. Well, I can tell you right now, I don't need supplemental oxygen, but I am absolutely 100% oxygen dependent. I have to have oxygen. If you put a plastic bag over my head right now, I'm going to fight like a tiger to get that off because I'm oxygen dependent. I have to have that oxygen. So they're worried about it, getting it, having access to it, and they're worried about what does that mean is happening with my lungs because now I have to have the extra oxygen.
Right, and then they're worried having to use it and embarrassed. There's a stigma with people that are going around with oxygen. So it becomes a double-edged sword and a real stigma, and also it adds to the suffering.
So they feel like their world is getting smaller. Mm-hmm. Now I need oxygen. I can't travel, and I really like to travel. My family, lives, away from here. Maybe it's just an hour. Maybe it's a flight to get to see some family members that they really want to see, and they feel like they can't.
People need connection, and especially when they're not feeling well, you want to have connection of your family and your friends just so you feel support to keep fighting or keep living the way that you are. Well, the biggest thing I think is when the mobility changes, when they have to go from, walking freely to now having to use a cane or a walker and then going into a wheelchair. That creates a lot of suffering because, that's a process, just like you discussed with the oxygen. This is a process of how to leave the home. And now you have to, have somebody that's already debilitated try to figure out how to close a walker, how to move it. They're weak. And then they don't like being attached to these devices because it takes away a sense of freedom to them.
Yeah, that independence. People of our globe are so independent and they want to be able to do for themselves. They like to be able to help themselves, help their family, help their neighbors, help their community. And I think that builds that community, but to not be able to be independent causes its own kind of suffering. And then I think it's associated with worry. What does this mean that I can no longer walk by myself? I have to be careful when I get up out of bed because if I just stand up, I might pass out. I might fall over. And I already feel like I'm at enough risk that if I stand up and I fall and I get hurt, things could be worse than they already are.
Mm-hmm. And then you think of, okay, well, with all these symptoms that I'm managing, what will that cause? Because when you have pain, you take pain medication. Well, that's not a benign thing. So there could be suffering involved with taking those medications.
Because of side effects or cost.
I think really what we need to also touch on is there are solutions to suffering. First, it's a good first step is identifying the suffering, right? If we find it's physical, usually there is an emotional component and even a spiritual component to be had with that. And try, as a palliative physicians, we can prescribe different medications to try to limit the suffering. And obviously, when we limit the suffering or take away the pain, we have to be very cognizant to not over-medicate, per se. So then there's not a double effect and causing more suffering, per se.
And as Dr. T has mentioned, being palliative physicians, we approach things from a medical standpoint, but it's not all about medicine. It's not all about necessarily healthcare, but treating a patient with serious illness from a palliative standpoint is mind, body, spirit. And so we work as a team. And oftentimes we will involve mental health, licensed social workers, counselors. We will involve spiritual advisors such as a chaplain. And we do want to interview and have a guest speaker as a chaplain because many people confuse spirituality and religiosity.
Right. And they are completely different. And honestly, I didn't know it until I became a hospice and palliative medicine physician, the differences, because that's not something that you are around when you're in the hospital as a physician. You're normally separate from the mental health, separate from the chaplains. That's not it. But in palliative medicine, we are a combined interdisciplinary team. So we work with them synergistically, and we get to see the benefits that the patients have.
So that's what the IDT is the interdisciplinary team. And it involves all of these different players because each one of us needs to work with the patient to address these issues of suffering.
when we peel back the layers of the onions and really, really, really get to know our patients, then you can really identify some things. I like to share with you a story. I titrated this young lady's medications to really high doses. She did have metastatic cancer, so we would expect metastatic cancer to be very painful in the dying process. But no matter what we prescribed, it was never enough, and she was always crying out, "I'm in pain, I'm suffering, I'm in pain, I can't go on like this." This patient went through 3 hospice and palliative medicine physicians before I took over the case, and she had a prolonged dying process. And my clinicians, I mean, we're all trained, and we're all trained this very similarly. So they've spent a lot of time with this family, but for whatever reason, I, spent a lot of time trying to figure this out because we've gone through lots and lots of medications. I'm sure you've had patients like this where you're titrating all these medicines and nothing is touching them, nothing is making them comfortable. So I just said, quite honestly to the family, I'm at a loss here. Like I admit, I'm a human. We need some collaboration. Is there anything that we're missing? And by golly, one of the family members said, "Well, her son's in jail." I said, "Wow." She goes, "Yeah, he's incarcerated." And to be honest, I knew this family. I knew this family outside of work. So I was a little taken back, like, wow, this is this big skeleton closet. So I just said, well, let's try to make it happen that we get a call from the son. And we set it all up with our interdisciplinary team, and the call happened. And within 24 hours, this patient passed. And that was her suffering.
And so she was comfortable being able to talk to her son.
Mm-hmm. And she was able to let go of this earth and let go of her suffering. She had a lot of guilt because she raised all her kids equally, and to have this, son that was incarcerated, it was a lot of pain and suffering.
And so sometimes those things happen beyond our control, beyond our ability, but it comes back to the patient and will cause them suffering. So we've got to work as a team with the physicians, with the mental health, with the chaplains to try to assist the patient to find out what is causing this suffering, what is causing this pain, because sometimes the pain is actually a manifestation of something other than the disease process.
Absolutely.
Certainly the disease may be at the root of the problem, but it may not be solely the responsible cause that's making that person have that suffering.
That's so true. With our jobs, it's so important for us to have open communication with even the family to be involved, because sometimes patients are embarrassed and they don't want to tell us exactly what is happening. And as you said, the interdisciplinary team, we are so lucky to have them support us.
To have that extra help. We spend a lot of time with our patients. Many physicians are limited with the amount of time that they're able to spend with a patient, and I know that's frustrating for patients as well as for physicians. I think, most of you would even comment that you would like to be able to communicate with your physician and have a little bit more time with them, but you realize time is such a precious commodity, and there are so many people who need the time of the physician that they don't get those minutes with them. With our discipline, it is a much more intimate relationship, and we have to develop that relationship rather quickly. And I know when I have the opportunity to work with students and with residents, I try to impress upon them that, yes, you have chosen a very noble calling, and you are given the opportunity to interact with people in a way that many people never get. What a privilege to meet someone, introduce myself. I am Dr. Bone. I'm your palliative and hospice physician, and that's the beginning of our relationship. And then within an hour, they are sharing with me some of the most intimate things about themselves and about their family, and they know that I'm going to hold that with the utmost confidence, but that I'm going to share what needs to be shared with the rest of the healthcare team so that we can address their needs and we can address their problems. And I think as young students, young physicians come into the reality that now you are going to be given that information and that sudden relationship, and realize that this is no laughing matter. We try to find humor. We have a terrible sense of gallows humor, and I'll apologize for that right now, but we try to keep it a little bit light if we can, because these topics are so heavy. They are so deep. But, what a tremendous compliment that I can walk in fresh to a relationship and this person is going to share with me some of their most intimate facts. And I know that and I hold that dear. And, it's just an honor and a privilege to be a physician and have that information shared with me. I want to be able to provide the best advice that I can for these people so that they know what I know as it relates to their disease process. Part of us earning gray hair and having some age behind us is it has given us to see disease trajectories and to know how things might progress for a particular patient and help them anticipate what might come next. Because I think fear is another form of suffering.
Absolutely. When you know what your disease is going to look like and what the trajectory will be, then you can have more control and you have less fear. And you can start to prepare, because that's really what our job is, to help you prepare for whatever time you have left and make it the most memorable and peaceful and pain-free and symptom-free.
I think physicians are your medical expert. It's not our disease. It's not our disease state. It's not our family. It's not our suffering. And I think a lot of physicians sometimes forget that and they try to take it on more personally. And what we need to do is we need to prepare the patient and advise them that, this is what your disease state is, this is how it's advancing, this is what we're doing about it. So they kind of have some idea of where we are right here now, where we're going to be in the next month, the next 6 months, the next 5 years. So the patient kind of has a plan. Now the plan may change because something could happen for the better, something could happen for the worse, but we need to kind of know where we are at each point along that plan so that patients feel more comfortable and they don't have that fear of the unknown.
Yeah, and that fear of the unknown is what causes suffering. So it's really imperative for physicians to take the time to speak with their patients and try to help them understand their disease process.
So we've tried to touch today on different forms of suffering, and we've learned that it's not all about pain, it's not all about shortness of breath, it's not all about weakness and mobility or immobility issues, it's not all about family interactions, it's not all about fear or fear of the unknown or fear of death, but suffering takes many different forms. Please let us know if you found another form of suffering that we have missed. You can certainly respond in the comments below, but we also have a private email that you can respond to if you're uncomfortable leaving a public comment. But sometimes public comments, that's good information to share with others. And so don't share personal information about yourself, but if you've got something you want to share, we more than welcome hearing about it, because we want to learn as well as teach.
Absolutely. And I think it's so important, even sharing the comments publicly, to know that you're not alone, right? Everyone has experienced some level of suffering in their life. And I think that also helps normalize the disease process. So thank you all for joining us today. And we hope we relieve some of your suffering. Right?
Yeah, we want you to not suffer.
Not suffer at all.
We want you to live every day, and we want you to remember that hopefully we only die once.
Yes.
And
if not, we'll teach you a lot more suffering.
live to the utmost every day of what quality of life means to you, and that it's okay for that to change over time.
So thank you all, and we'll see you next time.
Bye now.
Bye now.